Hello, everybody. Welcome to Rheumatology in Review. I'm Sam Good. This is the good stuff. Today, in honor of World Lupus Day, we will be discussing the new lupus nephritis guidelines. The guidelines came out quite recently in Arthritis and Rheumatology online. They're titled the 2024 American College of Rheumatology Guideline for the Screening, Treatment, and Management of Lupus Nephritis. Okay, so these guidelines came out quite recently, but ACR did preview these guidelines last year with some updated recommendations at the ACR Convergence Conference. And really, there's some exciting changes, including to screening, treatment, and monitoring. Today, we're going to focus predominantly on treatment because I think that's where a lot of the exciting changes have happened. And just to keep things brief, if you're really interested, you can absolutely check out the guidelines. They're easy to follow. They're really helpful. So I strongly recommend it. But today, we're going to specifically focus on treatment. Okay, these helpful figures came from the updated guidelines, and the big change here is for the management of class 3-4 lupus nephritis, and it includes what is now being called triple therapy. And that means steroids, mycophenolate, and then one of the treatment options below. This does not include things like renin-angiotensin aldosterone system inhibitors and hydroxychloroquine, which are also recommended. But now the amount of steroids that's being recommended is a little different. So they do recommend pulse dose steroids, although the range of pulse dose steroids is a little different than it used to be. And also the initial dose of steroids, you can see up here, is less than or equal to 0.5 milligram per kilogram per day oral with a max of 40 milligrams of prednisone equivalents. And then mycophenolic acid analogs, that is not different. But these options down here are different, and that includes the consideration of Belimumab, a calcineurin inhibitor, or Belimumab, or just a calcineurin inhibitor based on other symptoms. So Belimumab is being recommended for patients who also have extra-renal manifestations and or a GFR that's less than or equal to 45. You can choose calcineurin inhibitor or Belimumab for patients who do not have other specific risk factors, and you would just talk to your patient about what they prefer. And then calcineurin inhibitors are recommended for patients with quite a bit of proteinuria, so greater than 3 grams per day. But it also requires a GFR greater than 45 and not significantly elevated blood pressures. So that is quite new for these guidelines compared to the old guidelines. Also for class 5 lupus nephritis, the recommendation includes hydroxychloroquine, that hasn't changed, RAS inhibition, glucocorticoids, and or mycophenolic acid analogs, kind of upfront. That's for people who do not have a bunch of proteinuria, but if you do have a lot of proteinuria, they're recommending adding calcineurin inhibitors. So there's less of a question here if it's pure class 5. Okay, so there's a lot to cover in the guidelines, and obviously I'm just going through a small portion of them. I strongly recommend checking them out. A few other things that I thought were interesting are, if patients fail one type of triple therapy, they're recommending moving on to a different type of triple therapy, given patient preference in a conversation with your patient. But that also now includes anti-CD20 medications as a consideration, not really as a first line, but as a potential option for patients who maybe have failed other first-line therapies as part of the triple therapy regimen. The other thing they recommend is if patients are failing despite being on appropriate therapy for long periods of time, to do a couple things, and that includes, really importantly, assessing adherence. That's a huge concern in lupus. There's a lot of data that there's quite a bit of medication non-adherence. And then the other thing they're recommending is to repeat a biopsy if it really seems like they're on appropriate therapy, have tried appropriate therapy quite a bit, and are still not improving, to rule out things like thrombotic microangiopathy or alternative causes for kidney dysfunction in lupus that may not be from just lupus nephritis.